Once again, a little bit more of the esoteric or resistance mechanisms and whatnot. I have no financial disclosures. The learning objectives are the ones that are mirrored in your workbook chapter. I'm not going to read those to you. I am going to go through the agenda for today. We'll start with bacterial meningitis. We'll also use the case from bacterial meningitis to carry over to discuss some of our stewardship tools, including biomarkers, rapid diagnostic tests, and a small section on interpreting susceptibilities. And we'll also talk about some of the barriers to good stewardship, including resistance mechanisms and how to treat MDR pathogens. And maybe the last 10 to 15 minutes, we'll talk about immunocompromised patients, including neutropenic fever, care for the HIV patients, fungal infections. I will refer you to the workbook for solid organ transplant infections. Practically, it is really difficult to separate out the management of infections in solid organ transplant patients and those who don't have solid organ transplant. So for the purpose of the exam, I don't know how they can really test the difference between the two. So I elected to leave that for the workbook. The workbook also has a section on SCIP measures and other quality improvement measures. As of January 1st of this year, SCIP really no longer exists. So I also elected to remove that section from the slides. So I'll refer you to the workbook as well. So we'll start with the patient case. HK is a 42-year-old woman who presents to the ED from home with a mental status changes, lethargy, and a temperature of 39.4. Her husband also reports that she had a severe headache 24 hours earlier. The patient has no significant medical history, and the medical team has a very high suspicion of meningitis. So why does the team have a high clinical suspicion? It's really because this patient has many of the signs and symptoms of meningitis. In our case, the patient has fever, mental status changes, focal neurological deficits. These percentage here corresponds with the incidence of these signs and symptoms when a patient does have bacterial meningitis. Additional signs include headache, which our patient also has, neck stiffness, nausea, rash, specifically for Neisseria, seizures, and coma. So in this patient, once again, a 42-year-old female from home, which is the most appropriate empiric antimicrobial of choice? Please choose your answer now. 1 for ceftriaxone, ampicillin, vanco. 2 for ceftaz, amp, vanco. 3 for ceftriaxone, vanco. And 4 for ceftaz, vanco. Okay, wonderful. It seems like the majority of you picked C, which is ceftriaxone vanco. So in order to answer this question, we have to assess a number of things. 1 is where did the patient come from? 2 is the age, and 3 is the immune status. So this table is pretty familiar to all of you. It's from the IDSA guidelines, and it basically suggests that adult patients who are less than 50 years of age, the common pathogens are Neisseria and strep pneumo, and the recommended empiric therapy is vancomycin plus a third-generation cephalosporin. The idea behind vancomycin is to cover for penicillin-resistant strep. If you're greater than 50-year-old and you're from the community, you have to worry about the additional pathogen of Listeria. In that case, you would give vanco plus a third-generation cephalosporin plus ampicillin. In the case of a patient who is immunocompromised or has the meningitis from a hospital, including trauma, neurosurgery, or the presence of a shunt, as Dr. Brophy talked about earlier today, then it really broadens out the number of common pathogens that are available, including many of the enteric gram-negatives, your non-lactose fermenting gram-negative rods, such as Pseudomonas, Staph aureus, coag-negative staph, etc. So in this case, you really have to kind of broaden your therapy to include Pseudomonal coverage. So the empiric therapy of choice in this case would be vanco, cefepime, or ceftaz, or meropenem. So in our case, our patient is 42 years old from home, so vanco plus ceftriaxone was a good choice. So in terms of antimicrobials, the blood-brain barrier usually prohibits the entry of hydrophilic antimicrobials, and a lot of the antimicrobials that we choose to use are hydrophilic. The penetration can be greater in the presence of inflamed meninges, which patients with meningitis will have. But we do want to maximize our dose to ensure that we have good penetration into the blood-brain barrier. So this table is also available in the workbook, but it basically spells out the CSF penetration percentage as a ratio compared to your serum concentration. I'll highlight a few things. One One is you can see across the board, we really don't have a single antibiotic that penetrates the blood-brain barrier 100% of the time. So it's not uncommon for you to see CSF concentrations that are many-fold lower than your serum concentration. So with that in mind, it's important for us to maximize our doses. So the highest dose that's recommended in the PI, that's the dose that you want to use. So in the case of ampicillin, we're talking about 12 grams a day of ampicillin. For ceftriaxone, it will be 2 grams Q12. For cefepime and ceftaz and meropenem, we're talking about 6 grams a day or 2 grams Q8 hours. So we really want to maximize our dose. One word about piperacillin tazobactam. This 20 to 30% is really piperacillin. Tazobactam itself does not penetrate the blood-brain barrier at all, so it's not a great drug of choice to administer for patients who have meningitis, because you're essentially giving an unprotected beta-lactam at that point. So upon giving, or ideally before giving antimicrobials, we shouldn't delay antimicrobials. We should be obtaining a lumbar puncture. And the lumbar puncture, aside from sending for gram stain and culture, we also want to look at the analyses of the fluid. And the fluid itself can give us a lot of hints as to whether or not the patient has meningitis. So specifically, in bacterial meningitis, we'll see an elevated white blood cell count. We'll see an elevated CSF protein. This is because the blood-brain barrier is not intact, and therefore proteins can penetrate into the CSF. We can see that there's a lower ratio of CSF glucose to serum glucose, and this is because the bacteria is actually consuming the glucose for energy. And CSF lactate is not routinely measured, but some recent evidence suggests that it's a good diagnostic factor comparing between bacterial meningitis and viral meningitis, where it will be elevated in bacterial meningitis, but not necessarily in viral meningitis. And these numbers over here correspond to, by themselves, if your patient's CSF analysis has any one of these numbers by themselves, it is a pretty good predictor by themselves of a bacterial meningitis. So once again, we want to look at the CSF profile, and we also want to send the CSF gram stain for culture. Aside from CSF culture, blood cultures are also important. Blood cultures can be positive in upwards of 2/3 of all the cases in meningitis. Ideally, once again, we should try to attempt to draw it prior to antimicrobials, but we should not delay the administration of antimicrobials while waiting to give the antibiotics. And the reason why we want to draw a blood culture also is a lot of times we can use these results to help us de-escalate antimicrobials. So your CSF culture may not necessarily be positive, but your blood culture can be positive. And de-escalation, we're going to transition a little bit to stewardship now. De-escalation is one of the main drivers of antimicrobial stewardship. Per the IDSA guidelines, the primary goal is to optimize clinical outcome while minimizing unintended consequences of antimicrobial use. And so the secondary goal is to reduce healthcare costs without adversely impacting quality of care. So when we think about antimicrobial stewardship, a lot of times we're thinking about printing out a list of patients who are on meropenem and then going through patient by patient. But that's not necessarily the case. I would argue that most critical care practitioners are in fact already doing antimicrobial stewardship. If you look at cultures, if you make recommendations, if you recommend duration of therapy, then you're doing stewardship. And a lot of the stewardship principles will also apply to you in your clinical practice. And this secondary goal of reducing healthcare costs, many of the studies that have evaluated antimicrobial stewardship do see a cost benefit associated with it. So roughly speaking, 30% of a hospital's prescription budget is due to antimicrobials, and most of the time stewardship efforts can bring that down 20 to 30%. So how do we do that? How do we actually implement the recommendations of the guidelines? We can do so by improving the diagnosis and management of our infectious diseases. And to do that, we can quickly and accurately distinguish infection from non-infection, try to find out which pathogens are responsible for the illness, to assess the disease severity, assess the response, and define the length of treatment. Once again, I think all of you are already kind of doing parts of this stewardship. Thankfully, we now have a number of tools that can help us do stewardship a little bit better, particularly in the ICU. So what I mean by tools is there's now a number of biomarkers that are out there that can help us get to these answers a little bit quicker. So in terms of biomarkers, there are kind of species-specific biomarkers and non-specific biomarkers. Some good examples of species-specific biomarkers include beta-D-glucan and galactomannan for Aspergillus and Candida, respectively. Just a show of hands, does anyone use any of these species-specific biomarkers? Yeah, so you guys are pretty well familiar with it. So I'll just say a few words. For Canada beta-D-glucan, it's really a cellulose. It's found in the fungal cell wall of Canada. It's also found in many, many fungal cell walls. It's also found in PJP. It's also found in hemodialysis filters, gauzes, certain antimicrobials. It's elevated in bacterial infections. So there's a pretty high, it's not the most specific test. So for the ICU, I would say it's more served as a ruling out as opposed to ruling in. So if your beta-D-glucan is negative, it's more likely that you don't have a fungal infection. Whereas if it's positive, we don't really know how to interpret it. And I would kind of say the same thing for galactomannan. Galactomannan really originated from the hematologic malignancy world, where the prevalence is much higher for aspergillus. Because the incidence is much lower in critically ill patients, it actually has a much poorer positive predictive value in critically ill patients. So I wouldn't say it's super helpful. It's also, I have stated here that it can be used for ruling out, but it's also not the most sensitive in critically ill patients. The reason for that is galactomannan is released during aspergillus growth. However, it's cleared by neutrophils in the blood. So in patients who are non-neutropenic, the kinetics of galactomannan is very different from patients who are neutropenic. So when I say ruling out here, what I really mean is galactomannan can be measured in the BAL. So how many of you are measuring galactomannan in the BAL? A few. So there's evidence to suggest that the sensitivity is retained for critically ill patients in the BAL, and it's because patients who have invasive pulmonary aspergillosis, remember they have angioinvasion and it causes necrosis. So that necrosis actually prevents the clearance from neutrophils. Therefore, the BAL sensitivity for galactomannan is actually much higher than the serum for critically ill patients. So here are some of the disease-specific ones. There are other ones out there. When we talk about non-disease-specific biomarkers, the one that is studied the most and most likely to be tested is probably going to be procalcitonin. It is a non-specific bacterial biomarker. It is upregulated by bacterial toxins. It's also upregulated by the cytokines that are released in response to the bacterial toxins, including IL-1, IL-6, and TNF-alpha. However, it doesn't seem to increase by the cytokines that are released from viral infections, so it's specific for bacterial infections. It's used for the diagnosis and prognostication in sepsis, but I would say that there is not 100% sensitivity or specificity, not really even close. So most of the evidence do suggest that it has non-inferior outcomes and associated with a shortened duration of antimicrobials if you use a procalcitonin-guided strategy. It's probably best used for de-escalation. The reason being, because of the lack of 100% sensitivity, on day one of therapy, clinicians are really not inclined to follow the procalcitonin rules. In other words, clinicians are much more likely to believe themselves and their assessment of the patients as opposed to the procalcitonin results, which I also agree with. In fact, when used for escalation or initiation of new antibiotics, these are patients who don't have signs and symptoms of infection, and we're just checking procalcitonin every day. And when the procalcitonin is increased, we give them antimicrobials. In those patients, it actually led to worse morbidity, not mortality, just morbidity, more renal dysfunction, and more mechanical ventilation. So it's probably best used for de-escalation. There's a number of algorithms that are out there. This algorithm for procalcitonin is probably the most prominent one. And it basically suggests if your procalcitonin level is less than 0.25, that you can pretty strongly encourage stopping antibiotics. And if, let's say you draw procal on day 1 and day 3, on day 3, if it's 80% of your peak, or it's between 0.25 and 0.5, you'll encourage stopping antibiotics. On the opposite end, if your procal level is greater than 0.5, then continue antibiotics or even escalate. And if it's greater than 80% of your peak and greater than 0.5 mics per liter, then encourage antibiotics. So this is just a very simple algorithm based on number and a percentage of your peak concentration to determine whether or not you should continue your empiric antimicrobials. And once again, using an algorithm such as this is probably non-inferior in terms of patient outcomes, however, can decrease the utilization of antimicrobials. So we'll go back to our patient case. Recall HK has signs and symptoms of meningitis. We initiated her on ceftriaxone and vancomycin. We did an LP. It does reveal 1,500 white blood cells, protein of 150, glucose of 40. looking at her vital signs, she is hypotensive, blood pressure 90/50, tachycardic, heart rate of 101, high white blood cell count, and high lactate. Procalcitonin was drawn on emission, and the results were available within 12 hours after antibiotics were initiated. And the procalcitonin result was 0.1 micrograms per liter. In this case, which is the most appropriate option given the PCT results? Is it A, continue all antibiotics, B, discontinue all antibiotics, C, escalate antibiotics, or D, discontinue vancomycin only? Good. Seems the majority of you chose A, which is continue all current antibiotics. So once again, procalcitonin does not have 100% sensitivity. In this case, just go back to the case here, the patient clearly has signs and symptoms of meningitis and is hypotensive. So in this case, it probably warrants basically ignoring the results and continuing with the antimicrobials. So we'll continue with the case. Once again, the patient's LP is consistent with meningitis. The patient is still empirically on ceftriaxone and vanco. Nothing is growing on the CSF. However, blood cultures are now positive. Remember that blood cultures can be positive in up to 2/3 of the cases, and we can use the blood culture results to help with our de-escalation. So what is the issue with blood culture? One particular issue is we get the blood culture, and if it's positive, then we get the gram stain. And after the gram stain, 24 hours later, we get the subculture, and this is where we get like GPCs and pairs and chains. And then 24 to 48 hours after that, we get susceptibility, and then we get the results finalized. So from the moment of blood culture positive all the way to the results finalized, it could be 48 to 72 hours of lead time. And from the time that the blood culture is actually drawn, it could be 96 hours of lead time. So even though it can help us, it might delay the amount of, it might actually, I guess, prolong the amount of empiric antimicrobials that are given. So there's a lot of new tools out there, including PNA FISH, PCR, MALDI-TOF, nanoparticles, chromogr, chromogenic media, that can delay the time to identification of this particular species. So instead of being, 48 to 72 hours after the blood cultures are positive, we can cut down the time to 10 minutes, 20 minutes, 90 minutes, 30 minutes, etc. So just another show of hands. How many of you are using any of these rapid diagnostic tests? So a good number of you. So I'm just going to spend the next few slides kind of talking about each of these tests. So once again, these are the commonly used tests, and I have down here kind of in progressive fading fonts, the amount, this basically represents the amount of evidence for these kind of tests. So there's pretty good evidence that these tests can reduce the time of microbial identification, which makes perfect sense because that's what they're intended for. The evidence gets a little bit murkier when we talk about early appropriate antimicrobial therapy. I would say most studies would suggest that it can decrease the amount of time to appropriate antimicrobial therapy. However, there's there's really very few studies that actually identify that there's improvement in morbidity and mortality associated with the use of these tests. So the rapid diagnostic tests, they can be used for shortening the time to species and resistance identification. They have really good sensitivity and specificity, 90 to 100%. And once again, can decrease the time to change in antimicrobials. The effects are most pronounced when it's combined with a formalized antimicrobial stewardship effort. Essentially, if you just implement this in the lab and no one knows about it and no one looks at it, then it's not going to do much. However, if you who are rounding in the ICU can interpret these for the team, then it can make a great difference. And most of the studies also suggest that it's cost neutral or even cost effective with your decreased use of antimicrobials. Implementing these tests should not be a huge cost burden. There are limitations. They're not perfect. So the current systems, all the ones that I named, still rely on culturing. So it's not like you can take a vial of blood and stick it into a machine and it'll spit out a result. You still have to grow it in growth medium. And once you have identified that there's a positive culture, then you put it in a secondary machine to find the species identification and resistance patterns and whatnot. Most of the applications are only used for blood cultures. So even though they've been reported for BALs, its clinical application is not widely used currently. Currently, at least, most of them have an inability to detect polymicrobial cultures, so they can only identify one species. And if it's polymicrobial, it kind of just reject the results. And none of them give a full susceptibility information. So I kind of want to point out that this is essentially like a gram stain, but it's a much fancier gram stain. I'll give you much better information. So in terms of the individual system, PNA fish is one of them. It targets species-specific ribosomal RNA through fluorescent probes. And here is a little example looking at the ribosomal RNA of E. coli. If you apply these probes, E. coli will come out as green and Pseudomonas will come out as red. And that's the extent of the information of PNA fish. It really can determine, whether you have Pseudomonas or enteric gram-negatives. It can find out whether you have coag-negative staph or staph aureus. And a lot of these application requires you to interpret the results of this PNA fish. So it will tell you whether or not you have staph aureus or coag-negative staph. But you as the clinician still have to determine, is the coag-negative staph a contaminant or not a contaminant? It can tell you whether it's E. faecalis or E. faecium. And I would say most of your hospitals, E. faecalis probably is still AMP sensitive and maybe definitely vanco sensitive. And a lot of your E. faeciums are probably vanco resistant. So it will also take you to go back to your antibiogram and evaluate whether or not you would make any changes based on this information. Candida species, it will tell you whether it's glabrata or Krusei or albicans or parapsilosis. But once again, you have to know your local susceptibility patterns to kind of figure out what to do with that information. Currently, it doesn't give you any resistance information in resistance genes. However, that is in development. MALDI-TOF, let me see if I can remember what it stands for. Matrix-assisted laser desorption ionization, something along those lines. But MALDI-TOF, it's a much more fun way to say it. So it's essentially mass spec. When you grow a positive culture, they stick it in this plate, and then they shoot a laser onto the plate, and they look at the particle distribution of these particular plates, and they match it with reference standards for various species and also resistance genes. Currently, the commercially available MALDI-TOF system only gives you the species, but it doesn't give you the genes. So going back to PNA fish, these are really the only applications for PNA fish, and you're limited to whatever the company has to offer. However, with MALDI-TOF, you're really not limited by anything. You're limited by the amount of standards that they have out there, and every day these standards of these particle detectors are increasing. So eventually, we'll be able to identify every single species, every single resistance genes, etc. But once again, currently, we can't detect resistance. The last system I want to talk about is the microarray. This also goes by the name of Verigene, the commercially available product. I can't claim to really understand what it's doing. However, from what I can gather, they basically take microsegments of DNA and they match it to these nanoparticles of gold that has matching receptors for these microsegments of DNA, and then they augment it with the silver particle, and it spits out a result. The good part is that it's fully automated. You basically stick it in and it spits out a result. It has really wide application. So this is really the first system to be able to give us our resistance genes information. So it can have gram-positive, gram-negatives, and also resistance genes. It's similar to the other products. It gives you the resistance genes, but it doesn't give you the full susceptibility. So it still requires you as a clinician, and this is where I see clinical pharmacists having a huge role in interpreting how do we actually use these information. So this table is also in your workbook, but it basically spells out a rational approach to how do we pair up resistance genes and species and actually what we're supposed to do with the information. So MEC-A gene usually denotes that you have methicillin resistance, so you should be using vanco. VAN-A denotes vancomycin resistance, and therefore you should be using non-vancomycin. CTXM is an ESBL. Here's where it gets a little bit more murky. ESBL, we know that carbapenems are generally sensitive most of the time. There are times that they're not sensitive, and there are also times that you don't necessarily have to use a carbapenem. You can use something else. So I think giving a carbapenem when you have this information is reasonable, but you still have to maybe de-escalate further when you have more information with full susceptibility results. KPC would denote carbapenem resistance, and here are some of the potential therapies. NDM is a New Delhi metallo-beta lactamase. It's essentially a carbapenemase also, but it's different from KPC. Ceftaz-AV actually doesn't cover NDM, but does cover KPC. VIM and IMP also denotes carbapenem resistance, but it's restricted only to Pseudomonas. OXA is oxacillinases, and it also denotes carbapenem resistance for Pseudomonas and Acinetobacter. So I would say these are potential therapies, and you should be changing these when you have the resistance gene information. However, you should be still looking at your full susceptibility results and making your final decision based on your full susceptibility results. So we'll continue with our patient case. HK, who has meningitis. LP is significant for meningitis. However, the culture is negative. The blood culture is positive. And now we have blood culture positive, demonstrating E. coli. And we have Verigene in this hospital, and therefore it detects also the presence of a CTXM gene. So now what is the most appropriate choice for this patient's empiric antibacterial therapy? Is it A, to continue current antimicrobials, B, to stop Vanco and continue ceftriaxone, C, to continue Vanco and change ceftriaxone to piperacillin, or D, to stop Vanco and change ceftriaxone to meropenem? All right, wonderful. So all of you caught that CTXM equal ESBL, and therefore you should change the ceftriaxone to carbapenem. And we are not growing any gram-positive, so we can probably safely stop the vancomycin. So I guess I would say if I was writing a board question or the test question, it would be similar to this type of question. I mean, to answer this question, you would have to be able to interpret what the CTXM gene is, recognize what Verigene actually is, and identify that piperacillin doesn't penetrate the meninges, and be able to choose the correct answer. So I would say the board questions are probably going to be multimodal, meaning it's going to test multiple areas at the same time. So CTXM is only one type of our resistance mechanisms, and clearly resistance is a huge issue. Back to Dr. Bauer's lecture, he stated that the importance of giving early antimicrobial therapy within 1 hour from the onset of sepsis or septic shock. So what are some of our reasons that we don't give initial adequate antimicrobial therapy? Many times it's because we have resistance. And here we can see these are reasons for inadequate initial antimicrobial therapy. And we see resistance gram-negatives as a reason majority of the time. MRSA Canada. When we look at our CLABSI MDR rates, we see that they're really significant. KP is at 17%, Pseudomonas 15%, et cetera, et cetera. So resistance a lot of times is preventing us from giving the right antimicrobials. So we'll spend the next few slides kind of talking about interpretation of susceptibility results and antimicrobial resistance. So interpreting susceptibility results, I would say this is not a hard science, and therefore I think it'll be hard to test on a board type of exam. However, it might be important for your clinical practice. In general, higher MICs, even within a sensitive range, are associated with worse outcomes. What do I mean by that? Enterobacteriaceae, SOSIN MIC, breakpoint is 16. However, a bug with a breakpoint of 1, the patient is going to do better than if the breakpoint is 16. So I think it's important to take that into account even within the realm of susceptible, intermediate, or resistant. We should try to utilize the MICs to optimize our pharmacodynamic target attainment. A lot of times that includes looking at the MIC. It also includes looking at where the site of infection is. So for example, for meningitis, once again, the blood-brain barrier prevents penetration of a lot of our antimicrobials. So we have to realize that we need higher doses to reach those target attainments. And same thing can be said for if a patient's in shock and you need delivery into the lung tissue, that requires good perfusion because hydrophilic generally doesn't penetrate the lungs super well. Strategies to overcome slightly elevated MICs, and these are even a softer science. Basically, we're trying to give a higher dose or maintain a higher serum level so that the bug will respond better. And how do we do that? We can give loading doses, and for beta-lactams, we can administer them as continue or extended infusions, or just good old give higher doses. And a lot of times, as we talk further, when we talk about carbapenem-resistant Enterobacteriaceae, we really don't have a single drug that is perfect for the bug. Therefore, a lot of times giving combination therapy might be reasonable when we don't have any other options. So now we'll transition and talk about the various multi-drug resistance. ESBL is an acquired beta-lactamase, meaning it's plasmid-mediated. In pharmacy school, one of my professors said plasmid equals promiscuity. So essentially, these bacteria get around and they transition their genes to each other. And aside from a laugh, this is also important because within those genetic material, they also have resistance genes for many of the other antimicrobials. So that's the reason why cross-resistance, when you do have ESBL, is so high. That's why a lot of times ESBLs are resistant to fluoroquinolones. They're also resistant to aminoglycosides. It's because it is plasmid-mediated, and the plasmid has a lot of other information. If you do acquire this ESBL, it does hydrolyze all of your penicillins, your cephalosporins, and your striatum. Carbapenem does maintain activity, and traditionally carbapenem is considered a drug of choice for patients who do have ESBL infections. However, in this day and age of stewardship and carbapenem resistance, can we try to spare the use of our carbapenems as much as possible? We can. There's some newer evidence to suggest that beta-lactam and beta-lactamase inhibitors and cefepime might be okay options when you have certain criteria that are met. And here are some of the studies that have evaluated beta-lactam, beta-lactamase inhibitor, and also cefepime. I'll kind of go through this study first. This is a subsequent analysis of a bigger study. In the bigger study, they looked at roughly 200 patients with ESBL bacteremia. It was retrospective studies, cohort, and they compared patients who received piperacillin tazobactam compared to patients who received carbapenems. And in the bigger study, the one with 200 patients, they really didn't find any difference in mortality, suggesting that piperacillin tazobactam is an okay option to substitute for carbapenem for the treatment of ESBL bacteremias. However, they are retrospective cohort studies, so as you can probably suspect, the sickest patients, the ones with the highest inoculum of infections, they all got carbapenems. The authors did try to adjust for all that. However, how much do you really trust statistical adjustments? So this is, once again, the subsequent analysis of that study. And in this analysis, they only took patients that received piperacillin tazobactam for the entire duration of their course, meaning within 24 hours of the bacteremia and for the entire duration of their course. So they found 39 patients, and they separated them out based on the source of the bacteremia, whether it be urinary tract source or an other source. For urinary tract source, we can see across the board, regardless of what the MIC for the piperacillin tazobactam was, patients did not die. There was 0% mortality if it was a urinary source, meaning regardless of the MIC, if you have a urinary source, piperacillin tazobactam is probably a decent choice for ESBL type infections. However, when you have other sources, and these other sources included a whole bunch of other stuff, biliary, pneumonias, etc., we can see a stepwise increase in mortality as the MIC goes up. And the differentiation here is a high MIC was 16, an intermediate MIC was 4 to 8, and a low MIC was 2. Once again, these are all within the sensitive range of piperacillin tazobactam. It's just within the sensitive range, there's still a differentiation of whether it's high, intermediate, or low. And we can see that if you have a non-urinary source, the higher your MIC goes, the higher the mortality. So I guess I would say if you are using piperacillin tazobactam for ESBL, consider looking at the MICs and also maybe consider only using it for urinary source type infections. So this trend with MICs was also observed in this study. This was a study that looked at roughly 190 propensity match patients that had ESBL infections comparing carbapenem and cefepime. In the main study, carbapenem versus cefepime was actually inferior. So cefepime was associated with higher mortality when they did the initial analysis. However, when they broke it down based on, once again, the cefepime MIC, we can see with the same thing, a stepwise increase in mortality. These are all mortality, sepsis-related, 30-day, and crude. A stepwise increased mortality as your MIC went up. So the authors concluded that cefepime might be a reasonable option when your MIC to cefepime is really low in the presence of ESBL. So I guess I would also suggest if you're using cefepime to reserve it for patients who have an MIC that's really low. So to summarize, ESBL, carbapenems are still the drug of choice, particularly for patients who have severe infections. Significant resistance is seen with other classes. So that's why a lot of times your fluoroquinolones and whatnot are not going to be helpful. Piperacillin, tazobactam, and cefepime may be considered for carbapenem sparing strategies. However, if you do use them, I would consider it only when the MICs are known to be low. Consider using higher doses, once again, to optimize that pharmacodynamics. Use them for maybe lower inoculum infections, such as urinary tract infections, and maybe when patients are already all better, kind of consolidative therapy, so we don't need 14 days of carbapenem, but we can get away with the first 7 and finish the last 7 with one of these. Changing to AMC beta-lactamases, this is a different type of beta-lactamase. So if ESBLs were plasmid-mediated, these are chromosomal-mediated. So chromosomal, you can say, is purity, and plasmid is promiscuity. So these are innate. These are innate, meaning they're not acquired. So a lot of the cross-resistance that we talk about is not really a big issue here. So there's a lot of confusion with AMC beta-lactamases. I think most of us remember that they're inducible. So what does that actually mean? Inducible, essentially, innately, with each one of these bacteria, Enterobacter, Citrobacter, Acinetobacter, Serratia, Providentia, and Morganella, each one of these species, all of them from birth have these beta-lactamase, and they're all inducible. And what that means is, from birth, all of them are going to be resistant to ampicillin, first and second generation cephalosporins. However, they will retain susceptibility to third generation cephalosporins, piptazos, cefepime, and carbapenems. So by inducible, essentially what happens is, in the presence of beta-lactam, you're degrading the cell wall. In a normal bacteria, these cell walls are actually chewed up by this recycling protein called MD. When it overwhelms the system, it turns on this regulatory gene, and it produces the AMC beta-lactamase. Once again, every single one of these bacteria already does this from birth. So inducible really is kind of a misnomer. We really don't care about the inducible because this happens all the time. We really care about selecting out the ones over here. And the ones over here, we call them the D-repressed mutants. So we can see that they don't have the AMP-D gene. We also don't have the regulator gene. So these bacteria have mutated their AMC where they don't need the presence of beta-lactams. They're constantly pumping out tons and tons of beta-lactamase. And what does this mean? Essentially, these are going to be resistant to everything that these are resistant to already. However, they will also be resistant to your third-generation cephalosporins and your piperacillin tazobactam. However, it will retain susceptibility to cefepime and carbapenems. So why do I have Enterobacter and Citrobacter highlighted here, underlined? It's because these over here are most common with these two species, specifically Enterobacter cloacae and Citrobacter frundii. So if on your test you see one of these two bugs, I would think automatically to AMC. So traditionally, we believe that we can't use any third-generation cephalosporins to treat any of these bacteria. Any of these, regardless of whether they're the mutants or not mutants, we can't use third-generation cephalosporins. And why is that? It's because, if we use third-generation cephalosporins, we might select out the one colony of your D-repressed mutants, and then this D-repressed mutant will now grow into another infection with a much higher MIC. I think this is a valid concern. However, epidemiological studies suggest that this happens roughly 5% of the time. So once again, in the spirit of stewardship, if your patient is pretty stable, I would say using ceftriaxone to treat an infection that is sensitive is not unreasonable. So the question is, what do we do when we have these D-repressed mutants now? So we have selected them out, and now we have the D-repressed mutants. Traditionally, we always use carbapenems, because carbapenems we know always works. However, there's also evidence now that cefepime is equally effective. This is a study that's propensity match for cefepime versus carbapenem for AMC-producing gram-negative bacteria. And by AMC producing, I mean the mutants, the ones that are hyperproducing. It looked at 30-day mortality, comparing treatment of cefepime versus carbapenem, and essentially no difference. Looking at the adjusted odds ratio for mortality, also no difference. And specifically, when they looked at cefepime susceptibilities, they found that in these hyperproduction D-repressed mutants, cefepime still retained sensitivity 96% of the time. So once again, I think cefepime should be the drug of choice in the spirit of sparing our carbapenems. So in summary, AMC is seen primarily with Citrobacter and Enterobacter, and what the AMC meaning the D-repressed mutants. The third-generation cephalosporins and Piptazo may select out your D-repressed mutants, but once again, that happens pretty infrequently. So if you have a sensitive bug, I would still be okay treating them with ceftriaxone or piperacillin tazobactam. Carbapenems are considered the drug of choice for D-repressed mutants. However, cefepime may also be reasonable if you want to spare the use of carbapenems. Once again, they are chromosomal mediated, so they're not plasmid, not dirty. Therefore, cross-resistance to other classes of antimicrobials are less common. In other words, you probably could get away with fluoroquinolones and aminoglycosides or Bactrim, something along those lines. All right, we'll move on to a self-assessment question, number 5. 81-year-old male admitted to the MICU with CLABSI. Blood culture is growing pan-sensitive Enterobacter cloacae. Patient is being treated with IV ceftriaxone. On day 10 of therapy, the patient develops signs of infection. Repeat blood cultures do show lactose-positive gram-negative rods, and the patient is being maintained on IV ceftriaxone. Right now, what is the most appropriate action? Is it A, to change to Ceftaz, B, to change to piperacillin tazobactam, C, to change to meropenem, or D, to continue ceftriaxone? All right, wonderful. So this is a clear case of, once again, it only happens 5% of the time, but this is a case that it did happen, where we have selected out the D-repressed mutants. So the patient is growing a lacto-positive GNB on ceftriaxone after being on ceftriaxone for 10 days. So because they have previously grown the Enterobacter cloacae, you're suspecting that this is now a D-repressed mutants. And D-repressed mutants are going to be able to cleave ceftazidime. They're also going to be able to cleave your piperacillin tazobactam. So carbapenem in this case is the good choice. So carbapenem resistance is much more difficult. It's seen both in Acinetobacter and Pseudomonas. It's also seen in Enterobacteriaceae. The genes that mediate these resistance are different depending on the species. For the Acinetobacter and Pseudomonas, there's a number of genes that can lead to carbapenem resistance. And I guess the only thing I would say is it's much more difficult to predict what gene is actually mediating the carbapenem resistance for these bugs, whereas it's different for the Enterobacteriaceae. Generally, it's either they have the KPC gene or the NDM gene, New Delhi metallo-beta-lactamase gene. The cross-resistance to other classes of antimicrobials is extremely common. So a lot of times when you have carbapenem resistance, you pretty much have a pan-resistant bacteria. So what are some of our treatment options? We have the polymyxins, tigecycline, not for Pseudomonas because it doesn't cover Pseudomonas, aztreonam or non-beta-lactam antibiotic if it's susceptible, and once again, that's very, very unlikely. Phosphomycin can be used primarily just for UTIs. PO is the only form available in the United States. And we have a couple of new agents. We have Ceftaz-AV, we also have cetolizane tazobactam. We'll talk about those as well. And once again, we might not have a single great agent, so combination therapy is definitely an option here. So ceftolizane tazobactam, its coverage is really specific for multi-drug resistant Pseudomonas. It can cover ESBL and AMC-producing organisms, but once again, carbapenems can as well. It has limited gram-positive and anaerobic coverage. So I would say gram-positive anaerobic, think of it kind of like ceftazidime. No activity against KPC. So I would call ceftolizane tazobactam kind of a specialist. It's specialized in killing extended drug-resistant Pseudomonas. So even in extended drug-release Pseudomonas, ceftolizane tazobactam does retain good activity. The MIC 90 is below the MIC breakpoint, even in these Pseudomonas that are, once again, multi-drug resistant. The FDA has approved it for the treatment of complicated intra-abdominal infection and complicated UTIs. However, I would say clinically, at our hospital, we're really reserving its use for patients with multi-drug resistant Pseudomonas without other options. So we're being good stewards of our new antibiotic and trying not to use it very much, and reserving it for cases where we really have our back against the wall and don't have many other choices. Ceftaz-AV, its coverage is for MDR, Pseudomonas, and Enterobacteriaceae. It does cover your KPCs, so your carbapenem-resistant Klebsiellas. It also covers oxacillinases. So you would think right here that, Ceftaz-AV would cover carbapenem-resistant Pseudomonas. However, in laboratory studies, that's really not panned out. And once again, that's because Pseudomonas has a ton of different genes that can mediate carbapenem resistance. And the beta-lactamase, oxycylinase, is really only one of those genes. So ceftaz-AV, I would say, is also a specialist, primarily for KPC. Once again, it does not cover the New Delhi metallobeta-lactamase, but specific to KPC. It has minimal activity against Acinetobacters, gram-positive, and anaerobes. It is FDA approved for intra-abdominal infections. The one limiter of use here is it's pretty expensive, roughly $1,000 a day. I would say if the cost was not so high, a lot of our KPCs might be treated with ceftaz-AV. I mean, there's also not a whole lot of clinical data. A lot of the data is just in the laboratory. But I would say this cost is somewhat prohibitive for a lot of our use. So with that said, polymyxin and tigecycline still remain some of our therapies to be used for CREs and carbapenem-resistant Pseudomonases and Acinetobacters. So for the polymyxins, we have colistin A and B and polymyxin. It really seems like if you're from the East Coast or New York City particularly, you use polymyxin B. Everywhere else in the country, we use colistin. I don't really know why. So colistin is also available internationally, whereas polymyxin B is only available in the US, Brazil, and Singapore. One word about the internationally available colistin. Europe uses a different product that's dosed in units, whereas we dosed ours in colistin-based activity. So when you're reading a study on colistin, it's important for you to kind of do the conversions in your mind of what dose is equivalent to what dose. The mechanism of action for polymyxins is that it disrupts the cell membrane. It is primarily a gram-negative agent, so it only covers gram-negatives. It does cover ESBL, CREs, carbapenem-resistant Acinetobacter, Pseudomonas, KPC. So for gram-negatives, it's really broad. But there are some holes in the gram-negatives. It does not cover Proteus, Providentia, Serratia, or Burkholderia. One word that I would say about colistin in general, not necessarily polymyxin, but the majority of our country uses colistin. But I would say to date, we really don't know how to dose our colistin. So colistin was made in the 1940s. Back then, PK really didn't exist, and it really came back into favor when we start having all these resistance and we don't have any choices. The package insert dosing for colistin has changed recently, both in Europe and in the United States. There was a recent study that was in CID that evaluated the new doses and basically suggested that the pharmacodynamics of the new doses is still not good. So I would say, despite all the research that we've done so far, we still don't know how to dose this drug. Tigecycline is a 30S ribosomal subunit inhibitor. It is very broad, covers gram-positive, gram-negatives, including our multi-drug resistant organism, covers anaerobes, however, does have some holes, does not cover Pseudomonas, Proteus, or Providentia. The adverse events are somewhat mild, whereas colistin, we really don't know how to dose the drug because the PK really is non-existent. The tigecycline, we do know the PK. However, what we know of it is not good news. It is really widely distributed and therefore has low serum concentration, so not great for bacteremias. It also has poor lung penetration in terms of ELF. It also has poor urine penetration, so a lot of our blood infections, pneumonias, and whatnot in the ICU, it might not be a great choice by itself. And there is this FDA warning associated with tigecycline that basically suggests that tigecycline compared to other therapies have an increase in mortality rate. This was done by a meta-analysis done by the FDA where they looked at all the studies used for filing for the FDA labeling, and they noticed that tigecycline associated with a 4% mortality, whereas the comparators had a 3% mortality. I don't know for sure whether or not it has a mortality difference. This meta-analysis has been repeated now 4 times. 2 of them show a difference. The other 2 don't show a difference. But I guess it's suffice to say that the kinetics of it is kind of scary, and there's suggestion that it's worse than other therapies. So with that said, I wouldn't necessarily use tigecycline alone for CRE, just like I wouldn't use colistin alone for CRE, and that's why combination therapy makes so much sense. There's now several retrospective studies that have demonstrated benefit with combination using colistin, taiga, and carbapenem. There was a recent study that demonstrated that if you use a combination therapy with at least 2 agents with in vitro sensitivity, that it's associated with improvements. So not necessarily just any combination, but if you can pick 2 combinations that have in vitro sensitivity, then patients tend to do better. So patient case number 2, 54-year-old female treated for complicated UTI with cefepime, amikacin, and vancomycin. The preliminary results suggest a carbapenem-resistant Acinetobacter baumannii. Which of the following is the most appropriate recommendation for this antibiotic for this patient? Is it change to ceftaz-AV, change to tigecycline, change to ceftolozane, or change to colistin? Okay, a little bit of a split. So I just finished saying that I would never use colistin alone, but then I don't really give you a combination choice here. But remember, this is just a UTI. So the patient, I didn't also say, I didn't really give you anything, but the intention is that it's not a super serious infection. So recall, this is an Acinetobacter, and ceftaz AV really doesn't add a whole lot to Acinetobacter coverage. Neither does ceftolozane tazobactam. Tigecycline does cover it, but because of the urinary penetration, I would probably not use it alone. And therefore, in this case, of all of these 4 bad choices, colistin is the best bad choice. So I think that would be the answer here. Okay, we're going to really quickly talk about MRSA. MRSA vancomycin is still the king, I would say. It's still the drug of choice in most cases, and the guidelines would suggest, regardless of the MIC, whether it's 1.5, 2, as long as it stays sensitive, vancomycin, and I would say clinically, you would have to evaluate whether or not the patient is responding to your vancomycin to make the determination if vancomycin should continue to be used with a higher MIC. You can consider dapto as a reasonable alternative for bacteremia and endocarditis. It was found to be non-inferior in a New England publication compared to vancomycin for bacteremias and endocarditis. Linezolid is a reasonable alternative for HCAP and BAP. And ceftaroline now is another MRSA treatment that we have. And I would say it's a good alternative in cases where intolerance has developed to either linezolid or vancomycin. So we're thinking if a patient develops renal dysfunction to vancomycin and we give them linezolid and they develop thrombocytopenia. Ceftaroline might be a good option. It's just another tool in the tool bag for the treatment of MRSA. We do have some newer tools as well. Tedizolid was recently approved for ABSSSI, acute bacterial skin and soft tissue infection. Its claim to fame is, it sounds a lot like linezolid. It's in the same class, but its claim to fame is that it's less toxicity. There's really no hematologic toxicity, and there's also minimal interactions with MAOIs. Not that we really worried that much about linezolid MAOI interactions in the first place. It is also more potent. It does have a lower MIC compared to linezolid, and it even has activity against linezolid resistance species. However, I would say we really don't. The epidemiology of the importance of linezolid resistant species is to be determined. So I would say until there's more studies on this, it's currently being evaluated for hospital-acquired pneumonia. Until there's more data, I would say probably not a huge role in the ICU. Dalbavancin and oritavancin, these are our once-a-week vancomycins. So once-a-week drugs generally have no role in the ICU. So I would also say minimal role in critically ill patients. Okay, so we have roughly 7 minutes to talk about this side, but the saving grace is these are all in the workbook. So neutropenic fever, should be known to most of you. The definition is febrile, 38.3 orally or 38 for more than 1 hour, and an ANC less than 500 or expected to be less than 500 in the next 48 hours. The treatment really is on day 1 to give an anti-pseudomonal beta-lactam. With consideration to add on vancomycin, particularly if the patient looks really ill or has suspected CLABSI, SSTI, or pneumonia. So I would say most of your critically ill patient probably has a line. So if your patient's critically ill and they have febrile neutropenia, most of the time you're giving vanco and an anti-pseudomonal beta-lactam. The key is vancomycin can be stopped within 48 to 72 hours if your cultures do not demonstrate any gram-positives. And just like meningitis, with febrile neutropenia, you also want to maximize your dosing. The rationale being the dosing for normal beta-lactam is for an immunostable patient, immunocompetent patient, and that plays a huge role in the clearance of the bacteria. So with a neutropenic patient, you're really relying solely on the antibacterials. So if a patient is on day 4 to 7 of therapy and they're persistently febrile, now is when you would consider adding on fungal coverage, and usually here we would add something with mold coverage. Consider gram-positive coverage if it's not already been started, and consider giving dual gram-negative coverage at this point. Antibiotics can be de-escalated to a more narrow spectrum if the pathogen with susceptibility is available. The duration of treatment is generally 14 days and at least till ANC recovers. Growth factors such as GCSF or GM-CSF should not be used. If a patient was on it already coming into the ICU as part of their chemo regimen, it can be continued. But if a patient develops new febrile neutropenia, addition of GCSF does not improve outcomes. I'm going to skip this case. This is a case of febrile neutropenia with pan-sensitive E. coli. The answer is we can de-escalate, even though the patient is febrile. So a lot of times in clinical practice, it might be harder to do because of this febrile. However, if you read the guidelines, it suggests that being febrile by themselves for an otherwise stable patient does not require new antimicrobials, and rarely do you have more than one bacteria for a febrile neutropenic patient. So in this case, even though they continue to be febrile, you can de-escalate this therapy from 3 drugs to essentially ampicillin. All right, I do want to take a few minutes and talk about heart in the ICU. I was somewhat surprised by how much this was covered in my exam. I'm not saying that your exam will be exactly the same. However, there was a lot of heart stuff in my exam. So heart continuation and initiation is generally associated with good outcomes. This is especially true with opportunistic infections, whether that be tuberculosis or other opportunistic infections. One of the common reasons for not initiating heart therapy for ICU patients is the fear for IRIS, or immune reconstitution syndrome. However, even if patient exhibits signs of IRIS, the recommendation really is you can continue heart therapy unless the IRIS symptoms are really life-threatening. So corticosteroids may have a role in that case when you have really severe symptoms associated with IRIS and you still want to continue the heart therapy. In terms of administration, generally speaking, if a patient is already on a heart therapy and they come into your ICU, if you can't continue all of the heart therapy, you would not want to continue any of them. And the reason behind that is you don't want to develop resistance to a particular antiretroviral therapy. It's important to look out for some of the ADRs. Pancreatitis is common for all of your protease inhibitors. Rash can be seen with abacavir and nifurapine. And lactic acidosis they might still ask this question, even though no one uses these NRTIs anymore. However, lactic acidosis is common with your stavudine and didanosine and whatnot. Drug-drug interactions clearly is very common, especially with protease inhibitors and your anti-TB regimens. Specifically, rifampin interacts with pretty much all of your heart therapy. However, rifabutin is a decent substitute for rifampin in TB. The next few slides will talk about the opportunistic infections. So PJP, in terms of prophylaxis, we generally start prophylaxing when the CD4 count is less than 200. And the prophylaxis regimen, it can be, the regimen of choice is Bactrim 1DS daily or 1 single strength daily. The full list is actually in your workbook, but this is just a preferred therapy. In terms of treatment, Bactrim is also the drug of choice. High dose, 15 to 20 milligrams of your trimethoprim component, the VitaQ 6 to 8 hours for 21 days. And for patients who have severe hypoxemia, and that's defined as a PaO2 of less than 70 on room air, or an A gradient greater than 35 on room air. So if your patient is requiring supplemental oxygen, a lot of times they already have severe hypoxemia. You should consider giving prednisone in conjunction with the Bactrim. The rationale being PJP is a high burden load infection, and when you give antimicrobials, a lot of times the cell death of the PJP leads to an inflammatory reaction that puts the patient in ARDS. So the prednisone really kind of is there to prevent that from happening. But we really care about it for patients who have severe hypoxemia. Other prophylaxis, Toxo, when your CD4 is less than 100 and your baseline IgG positive. And the treatment prophylaxis here is 1DS Bactrim once daily. Of note, it's very similar to this regimen. However, the 1 single strength daily Bactrim for PJP does not cover Toxo. For MAI, if your CD4 is less than 50, consider giving azithromycin 1,200 milligrams weekly. There are these other opportunistic infections that we will only give secondary prophylaxis, which basically means once they develop the infection, then we treat them for life or until their CD4 count recovers. I'm going to skip this case as well. Final words on antifungals. So I have 2 minutes to talk about all the antifungals. So I'll try to be as brief as possible. So this is just a chart of the coverage of all the antifungals. And a couple of notes. For all of your azoles, Glibrata is the same for all of your azoles. So moving from fluconazole to Vori to Posa to Iza does not add more Glibrata coverage. It does add Cruzii coverage. Echinocandins cover kind of all of your Candida species. However, does not cover many of your molds. The only exception is Aspergillus. Isofluconazole is our new kid on the block. It has an indication FDA for Mucor, which is unique amongst all of the antifungals. In vitro-wise, the susceptibility for POSA versus ISA is very similar across the board, so I put them in the same column here. Let's move on. All right. Azole, specific characteristics. ITRA, I would say reserve it only for histo or other endemic fungi. Voriconazole, so all of the azoles have drug-drug interactions, but of all of them, I would say Vori has the most press. So if you have a drug-drug interaction question regarding Vori, I would say, involving the azoles, I would say most likely you have to be with Vori. In terms of Vori, the drug-drug interactions, it is a 2C19 and 2C9 substrate, and also an inhibitor of 3A4, 2C9, 2C19. By the package insert, it is contraindicated when you have a creatinine clearance of less than 50. It's because of the IV component has a diluent that is not cleared renally. Vori is the drug of choice for aspergillosis. POSA is really wide spectrum. It used to have a lot of PK issues when we only had the capsule, but now we have the delayed onset tablets, IV, suspension, so the PK issues really don't hold true anymore. Isofluconazole, similar spectrum as POSA. However, linear kinetics, PO and IV is the same exact dose because of high bioavailability and no QT prolongation. It shortens the QT. Other antifungals, ANFO, we all know the adverse effects associated with ANFO. I would say ANFO is, it has a really wide spectrum of coverage. However, there's not a specific condition that would really use ANFO in. Usually it's second line. The only exception, I would say, is for the treatment of cryptomeningitis in conjunction with flucytosine. You should be using ANFO in that situation. In other situations, usually is when other therapies have failed. Echinocandins, there's a recent guideline that came out. It's now the drug of choice for invasive candidiasis, particularly for critically ill patients. The guidelines do state that you can transition back to an azole when the patient is stable. So I apologize that I went over by a few minutes, and I went in a whirlwind speed in the bend. So I will be available for questions in the back if you guys all have any questions. And I thank you for your attention. You guys have been a great audience. And once again, don't forget to fill out the evaluations. That'll be very helpful for us. Thank you very much.